Welcome to Inside Aesthetics, the world's leading podcast for injectors and cosmetic businesses. I'm Dr. Jake Sloan, an aesthetic doctor based in Sydney, and I'm joined by my co-host and good friend David Segal, an entrepreneur and an aesthetic business mentor. Each episode of IA showcases unfiltered conversations with guests from around the world. In a sometimes disjointed industry, IA aims to help educate and connect our global community to raise the bar for both our businesses and our patients.
To further support and educate our listeners, we offer a range of additional resources under our IA Patreon subscription service. This caters for injectors and business owners of all levels and includes interactive live Zoom sessions, webinars, hints and tip videos, private chat groups, and exciting future content to come. To subscribe to IA Patreon, head to www.insideaesthetics.com/Patreon or click the link in our podcast description. You should seek medical advice before undergoing any treatment or procedure, and these podcasts do not replace a professional and bespoke consultation.
Happy belated birthday, friend.
Oh, thank you. Yeah, it was last week. It's almost a week tomorrow.
I haven't seen you
since we turned 43.
We have Stephen, we have the same birthday. It's very weird.
Is that right?
We don't have the same parents.
Happy birthday.
You don't have the same parents. Yeah, very good.
Yeah. What did you get up to?
Just family stuff. I might be doing something this weekend, but
nice.
We'll see. Nothing too crazy. I think after 40, I just sort of start forgetting about them now.
Yeah. It's just best to forget that ever happened.
Exactly.
And how's business consulting?
Yeah,
and
good.
Life?
Busy consulting, busy doing Patreon content. So
excellent.
I don't know. I just seem to be talking about business all the time.
Well, that's kind of what you do, right?
It's good. Yeah, I guess it is what I do.
Excellent.
So I'm excited for today's chat though, because, well, you know how I feel about collagen and skin tightening, and
if there was a king of collagen, you should know about this stuff.
Exactly.
But today we have an expert, Dr. Stephen Lowe from Sydney. Stephen, how are you today?
I am very good. Thank you for having me on here. It's exciting.
It's our absolute pleasure. Now, we're excited about this one because David likes collagen, but two, we've never actually tackled this topic before, which is, let's call it micro-focused ultrasound, but better known as Ultherapy. And I guess we haven't tackled it, one, because we didn't know an expert, but now we do. So we're excited to hear what you have to say. But also, there's lots of devices, lots of seemingly pseudoscience, and lots of, I guess, anecdotal varying feedback from patients who I've, spoken to in person.
Yeah.
So,
you walk into a conference and you're just seeing stalls of device companies all talking
selling
about
selling
you a dream. And as you said, the results are sometimes mixed. Patient selection's important. Some people say they work, some people say they don't. And so here we are. Here we are. Stephen, where is your accent from? Because I heard it and I got very confused. It sounds like it's Welsh, maybe Scottish, maybe where?
I'm going to say Ireland.
Ireland is Irish?
I'm going to let you keep guessing. No, I'm Scottish. I was born in Perth on the east coast of Scotland. I grew up further north, up in the hills of Scotland, up in the Highlands.
Right.
And I moved here 15, 16 years ago.
Right.
But my accent remains.
Yeah. My family's from Aberdeen, so I don't know how far that is from...
Oh, really? Yeah.
Yeah.
Yeah, not too far from there.
We might be related. There you go.
It's a very soft Scottish accent. It's nice. I mean, all Scottish accents are nice, but it's softer. Is that traditional from the area?
Yeah, the further north, they do have a softer accent. It's a little bit more, it's not Irish, but it's kind of a softer, like Irish rather than...
There you go. I knew there was some Irish
something. Have that harder Glaswegian accent, which is hard to understand.
Yeah, I found it gets broader with every drink.
Yes, and faster, broader and faster.
Anyway, back to Ultherapy.
Yes, back to Ultherapy. And we should say, today's episode, we're partnering with Merz Aesthetics, so they've kindly provided our expert, and we had a look at some of the publications and obviously some of the data from the device as well. But Stephen, why don't you introduce yourself? You've told us a little bit about where you're from, but tell us about your aesthetic background, your training, and I guess, what do you do now? I know where you work, but tell our listeners who have never met you before.
So I've been a doctor for over 20 years. I studied in the UK, moved here 15 years ago. My training was in Dundee University in Scotland. I have postgraduate fellowships in general practice and in aesthetic medicine. I'm a fellow of colleges of aesthetic medicine and general practice. I like academia, so I have master's degrees in public health and in aesthetic medicine. I really focus all my time now. I was trying to think, I was thinking you might ask, how long have I been doing this? And I had to go back and look at when I did that classic course that we probably all did, where we just did that one day, tops in the morning, filler in the afternoon. And that was 13 years ago. So I've been kind of doing this for a little bit of time. And then I committed full time to cosmetics about 7 years ago. I gave up general practice.
The weekend expert degree.
Can I ask, where did you learn the dark arts? Who did the one-day course with you?
So it was in Sydney. It was in the city. It was that that kind of classic Allergan training morning session with one product, and then the afternoon with filler. But I mean, it served a great purpose. It gave me a taster of just what this world was all about, and it's just that stepping stone into further training.
Yeah.
So I mean, I have no regrets about the path I've taken.
Yeah, and I guess as well, what we know today is infinitely more than what we knew 13 years ago. So in terms of the complexity, the complications, things like occlusions weren't really spoken about back then. We didn't have the plethora of treatments and cannulas. And so I think it's sort of evolved. And so the training probably is evolving and hopefully will continue to evolve over time.
Look, we've all done the same thing, and yet here we are, relatively successful. Yeah. So it kind of works, but I think we've learnt our lessons, and there's certainly better ways of learning now. But anyway, moving on. Let's maybe restart this conversation by maybe revisiting facial aging first, because, the Ultherapy device, as you're going to tell us, it's about collagen stimulation and maybe even tightening and lifting of the tissues. But what are we trying to treat? So maybe just recap for our listeners who potentially are newer on their journey or newer to the podcast. What, I guess, do we mean by facial aging when it comes to what Ultherapy might, treat?
I mean, some of this will be familiar to your listeners, as you said, but we have to think about aging on that multi-layer concept. This idea that I think we used to have, where we just looked at the surface and then decided, what people needed just based on what we could externally see. I think that's evolved. I think as our anatomy has improved, as our understanding of what actually aging is, we really have to think about aging being multiple layer. We have to think about what we see on the surface with the skin and with the dermis, but these layers underneath are doing an awful lot and contributing an awful lot more to what we're seeing on the surface. So obviously changes in fat pads, we know that the superficial and the deep fat compartments vary in different ways with the aging process, but we know that collagen-rich structures, so ligaments, tendons, this fibrous fascia kind of system that runs through our face, that's full of collagen, and we know that with aging and with cellular senescence and things flowing down, that the collagen in these structures is affected as well. And that's really this kind of scaffold system that's running through the face from right down on the bone, which of course we know there's bone changes happening in the aging process as well. So there's this multiple layers of impact from bone, from fat, from this fascia network, from the muscles themselves, and of course what we see on the surface, the dermis. So I think Ultherapy, when we come to talk about it more, I think Ultherapy is thinking about that multi-layer scaffold system. And I think if you're not thinking about the face in these three dimensions, I think we're probably not hitting the spot with our treatment.
Yeah. And so as someone that offers a modality of treatments, in terms of like making a clinical decision as to which way you're going to proceed with all the tools you have in your armory, where does sort of Ultherapy fit into the decision-making process? Is it patient selection, patient specific? Is it sort of age specific, or is it a bit more complicated than that?
I think it's for people who are really wanting to kind of tackle this aging process longer term. It's not a quick fix treatment. It's not a treatment that you're going to get instant improvement and satisfaction from after a few days, like you would with toxin or filler. I think it's for people who are committed to really tackling this aging process longer term, and they're thinking bigger than just quick fix today. They're really kind of willing to invest in doing things that will improve the structure and the integrity of the multiple layers of the face, and really start to kind of tackle what's going on globally with the face, rather than just kind of zoning in on one area. I think we do, as you mentioned, have to be careful about patient selection and about when we introduce it to people. But I think it's for people who are moving on from just quick fix, short-term solution. They're thinking longer term.
Talking about investing in your face, I've met you, Stephen, and you just said you've been a doctor for 20 years, and yet you look, I mean, amazing. And genuinely, you could be in your teens, like seriously. So have you done Ultherapy yourself? And if not, what else are you doing? And maybe we'll get a video of you for our YouTube at one point where people can see you as well.
Yeah, of course. I have most certainly had Ultherapy. I have at least one a year. Sometimes if I'm feeling greedy, I'll have 2 a year. I look after my skin. I'm a little bit skin focused. Our whole clinic setup is very skin focused. I like my lasers and I like skin treatments. And I'm really about confident stuff as much as possible. We, as a clinic, we offer, tightening and lifting treatments like Ultherapy, but I'm very focused on skin. So I use an excessive amount of skincare at home in my bathroom cupboard. I have lasers. I definitely have Ultherapy. I don't overdo anything, or I try not to. I don't have an awful lot of toxin filler. I have in the past, but that's not my main focus. Is really trying to keep things lifted and the skin quality better, to be honest.
Yeah, I think it's where we're all going, to be completely honest. But especially, I guess, the Merz portfolio with Ultherapy, toxins, fillers, and so on. You do cater for all of that.
Yeah.
Yeah.
In terms of educating the patient, because this is something that sometimes is a very difficult conversation for clinicians to have, is talking about the long-term benefit of waiting for these treatments to sort of take effect. Collagen takes, 90, 120 days to kind of remodel itself. So I know a lot of the challenges that clinicians have out there is, how do you sort of consult a patient for this type of treatment and sort of take them on that journey and get them to appreciate that, in a world where we're sold, as you said, these instant fixes, fillers is almost instantaneous, toxins within a few days to, a week or two. So how do you approach that conversation with the patient and the education side of things?
So in the clinic, my first appointments or my assessment appointments they'll be clearly driven by what the patient is looking for. But if they're open to a bigger conversation about this whole kind of process, I was going to say journey, but journey is a little bit, but it's true. I mean, it's a long-term partnership with some of these people. And I think the better they understand what you can offer, both short and long term, the better your relationships are with these people. I've been seeing some of these people for many years, and it's because there's a degree of trust in the process that people will be accepting of my opinion because they've been happy with what we've done before. But I think you just have to explain things. People are eager for knowledge. They're eager for information. They want to understand both the short and the long-term benefits of these treatments. And so I think my initial consultation or subsequent consultations will talk long-term. We'll talk about, okay, this is really what the plan is for today and for the next month. But we need to be keeping you looking good for your next birthday and your 40th and your 50th and those milestone birthdays. And when I think they trust you and when they're willing to go on that longer term process with you, then I think that conversation about doing these bigger treatments that are not going to deliver instant improvement, they're more willing to kind of come on board with it. Ultherapy is probably not the treatment I will rush to talk about in the very first appointment. It's rare that I would ever do it in the first appointment with somebody, mainly because you don't see instant improvements or mild improvements with the immediate after treatment. This is investment. This is long term, and so I think you have to build that connection and that relationship and that partnership with people.
Yeah. So I'm assuming you're starting with quick wins. So toxins, it's reliable. It's always going to. Well, I know we've got some issues with resistance popping up here and there, but I mean, for the most part, it's reliably consistent. Fillers are instant. So you're saying you're building the trust first, so getting some quick wins on the board and getting them some great results, building the relationship and the rapport. And then in subsequent consultations, whether it be 3 months, 6 months down the track, then you start introducing this type of conversation because the trust is there. They understand you know what you're doing. They're comfortable. And then you're going down that path. Is that kind of the way you're thinking about it?
Yeah, typically. Certainly if I see somebody new, that would be my approach. If I've been seeing somebody who's been having regular treatment for a long, long time elsewhere, and then they come to our clinic looking for a different solution, then I might introduce cell therapy from the beginning. If they've been having treatments, but they're just not quite getting where they want to, then I might recommend Ultherapy straight up. But it's I think it's important with these treatments where there's not instant improvement. Not that I think we should be aiming for instant improvement all the time, but I think when we are, I think when we're thinking long term, I think you need to get trust. You need to get people to believe in you and to trust in what you're offering and to be willing to part with their well-earned money to do these bigger treatments.
Yeah, I couldn't agree more. Toxin for me is sort of a gateway treatment where we build a bit of rapport. We talk about facial aging. I get them to understand some tangible things that are going to subtly improve on their face. And then if they come back happy and they say, hey, I like that, what else? Then you can introduce more complicated things. We mentioned the word collagen a couple of times. Now, you're the king of collagen, so I'm not going to ask you. But Stephen, why do we lose collagen? And can you truly make it again? Or are there different mechanisms at play?
So collagen is, as I'm sure most people know, it's one of the most abundant structural proteins that we have in our body. So it makes up a good chunk of our extracellular matrix, and is present in not just skin. I think we have to remember that it's present in multiple tissues. So in tendons and ligaments and bone, it's throughout our body in various forms. There's a lot of different forms of collagen. There's probably over 20 types of variants of collagen. In the skin and the kind of soft tissues of the face, it's mainly collagen type 1 and type 3. And there's the constant turnover of collagen, like most things in our body. There's a mechanism for replacing old, frayed, degraded collagen and replacing it. But the systems we have in our body, they just become senescent. Things slow down. Everything kind of just, eventually the cells that are capable of making collagen, the fibroblasts, become senescent. They stop doing what they want to do or what they're programmed to do. The problem is it's not just that they go quiet. They actually start to increase production of other enzymes, and they can actually degrade collagen. So they can have an adverse effect even when they've gone quiet. It's not just that they're quietly sitting in the background doing nothing. Actually, they can start to enhance breakdown of collagen. The collagen that they are producing tends to be fragmented. It's not as mechanically robust and as strong. The quantity of collagen that the fibroblasts are able to make is lessening. So there is this kind of progressive loss of quality of collagen, abundance of collagen. But even the collagen that we are making, these fibroblasts, these aging fibroblasts are actually encouraging the collagen to degrade. So we need to, and that's normal. That's part of the aging process. That's just biologically what happens as we age. But there's things that we can do to kind of reinvigorate those fibroblasts, to waken them up, to activate them, to re-stimulate them, to start producing quality collagen again. And they have the capacity to grow collagen again. They just need to woken up.
Yeah.
I was going to ask, just to build on David's question about, assessment and maybe who's a candidate and how you speak to patients. I often find injectors, especially, maybe more junior injectors, it's very hard for them to look at a face and understand what the difference is between, say, collagen loss and elastin loss, or both, or superficial wrinkles versus deep wrinkles. So when someone loses collagen, what do you see when you look at a patient's face? What are the signs and symptoms?
So collagen, on the most part, will give skin kind of mechanical strength. It gives it physical kind of resistance or bounce to the skin. Whereas, we lose elastin as well. Our elastin changes, it becomes thicker and more fibrous and less flexible. But elastin, that other protein in the skin, that is going to give skin more stretch and ability to recoil. So, and usually the process, fibroblasts make elastin as well. Usually that process is running in parallel. I think the thing I notice when I look at skin is when they have skin that when you squeeze, you can see the skin just buckling into like a concertina, just kind of collapses down. That's primarily elastin as its primary loss. And so when you release it, it doesn't spring back. It kind of just stays in that corrugated pattern. Collagen, when you squeeze skin with loss of collagen, it will collapse. But it's kind of got buoyancy, it's still got thickness there. It's elastin that makes it bounce back. But it's the combination of the two. And actually, treatments like our biostimulators, collagen stimulators, and Ultherapy will stimulate both elastin and collagen. So you're getting the best of both worlds. But the thing, as we mentioned earlier, these things are never happening in isolation. Clearly, the fat is changing at the same time, as we spoke about earlier. These multiple layers of changing. There's changes happening in the foundation, the actual structure of the skin of the face with the bone. So often what we're seeing on the top is a reflection of what's going on underneath as well.
Yeah. So maybe let's sort of just get to the obvious question, or for me, and I guess maybe laypersons that are listening to this or people that aren't familiar with the technology, is what exactly is Ultherapy in terms of how long has it been around, how's the technology changed over the time? And then for me, how does it kind of differ from the different technologies that are on the market that are promising or reporting to do the same kinds of things in terms of results?
So Ultherapy, its kind of technical name would be microfocus ultrasound with visualization. So that's its kind of category.
Mm-hmm.
And that really means that it's able to use ultrasound as its basic technology. So the ultrasound with Ultherapy in particular is able to be utilized in two ways. So we can have therapeutic ultrasound, where the ultrasound energy is released from various transducers that we can use and apply to the surface of the skin. And the ultrasound energy is able to be concentrated to pinpoint focuses under the skin surface. But it also uses diagnostic ultrasound, so we can see this happening at the same time. So your listeners will be very familiar with diagnostic ultrasound. If you have a scan of your gallbladder or your baby or something, we can see these images. And so Ultherapy is able to allow us to see images of the skin as well. So as we're treating, we're able to visualize underneath the skin surface. We can identify the dermis and the fat and the fascial structures in the bone, and we can kind of work out exactly where we're going to deliver the energy because we can see it. So it has this dual benefit. So the ultrasound is used in two ways: therapeutically to deliver heat or to create heat by concentrated ultrasound, but also diagnostically so we can see under the skin surface. It's been around so it was launched in Australia in 2014, but it was globally launched back in 2008. I think it's been around for a while. The technology actually hasn't changed too much in terms of the machine has altered a little bit over the years, but the fundamental technology of being able to focus that energy very precisely has been the foundation since it was launched.
Yeah. And so how does it kind of differ from other devices on the market, as I said, that promise the same kind of thing? So when patients that might come into your clinic, for example, and say, I've had treatments elsewhere before. I don't want to talk about any other devices, but I've had a treatment somewhere else. I paid all this money. I was, told I'd get this kind of result. It hasn't really done what I'd hoped it would do. How do you kind of tackle those questions? Because I'm assuming a lot of people listening who have devices or have had treatments have experienced this or heard from patients that have experienced this. So how do you kind of deal with that kind of question, and what is the answer to that question? How is it different?
I think people would refer to them as HIFU.
Right.
So high frequency, highly focused, ultrasound or whatever. Yeah.
And HIFU, HIFU is a category. Ultherapy is a variant of HIFU. It uses focused ultrasound, as you said. HIFU is a kind of an umbrella term. I think it's like laser. There's lots of devices that fall under laser, and there's lots of devices manufactured that would fall under a HIFU category. Which we can come back to later, but yeah, it's the visualization. It's the main thing that differentiates Ultherapy from other HIFU devices. It's being able to see what you're doing. You with the other devices, they are firing energy, and we can talk about that. There's variations of how they fire energy and how they deliver that energy. But the key thing for me, anyway, for the difference with Ultherapy is it's been able to see what you're doing. Because I think that, to come back to your question, David, I think that translates into results. Because, there's a bunch of reasons why people might not get the result that they were expecting. And that's not necessarily just the machine. That could be patient selection or how much they committed to the process of making their body healthier and abstaining from things that we know don't help the healing process. But there's a component of the treatment. Clearly the treatment has to work. So it's about having confidence in the treatment, but it's about looking looking at the treatment and understanding what potentially it can do, understanding the science, which I think is important. We need to understand what these machines have the capacity to do, and then know what they can't do so that we can apply it to the right person. And I think if you can narrow down all those variables, you can deliver treatments to the right people with the right expectation, and they get good results. It's all about, as you mentioned earlier, it's about patient selection, but it's about being honest about what any machine is capable of doing and what it's not able to do. I do lots of laser. I don't claim that every laser I use is going to give somebody flawless skin, but I can use a certain laser that's going to do more to give flawless skin. So you just have to know what these machines are capable of and what they were designed for and what they were not designed for.
Yeah. So who is the perfect patient? So if you had to sort of design the characteristics of the patient that's going to get the best results, what does that person look like? Maybe not even look like. I mean, I guess you want them educated enough to be able to understand what it is that you're talking about and be vested in, long-term results. So for people listening, what's the candidate they should be trying to filter in their clinic to have a chat about these types of treatments?
I think the ideal people are fundamentally people who are not looking for quick fix. They're invested in long term. So I think that's the first thing. They're not somebody, you're going to really disappoint anybody with a treatment that's going to take 3, 6, 9 months to see the full benefit if they're expecting it to be better by next week. So you have to weed out those people from the beginning, unless you can really educate them about what they're trying to do longer term and they are on board with that. You want people ideally who have relatively early signs of the aging process. I think if we can get on top of these processes earlier, we can kind of just nudge them in the right direction again. When you see somebody who is clearly going to be a better candidate for a facelift, they should be recommended for a facelift. And if they're not willing to go down that path, then you can have the discussion about Ultherapy again. But Ultherapy is not a substitute for a facelift. It's a treatment for people who want to improve what they have. And I think tighten, lift, I think those are acceptable words to use with Ultherapy. I think it does tighten and lift. But it's not for people who are at a stage where they need multiple mils of filler to revolumize, where they have so much redundant excess skin that nothing is going to get that to the level that they want improvement without surgically excising it. And so you have to, for anybody who presents themselves, we have to just understand you've talked about this lots of times in your podcast, but it's setting expectations and setting goals. In an ideal world, if I could line up the key people, I think it's people in their late 30s, 40s, who are just starting to get, a little bit heavy on their jawline, who are just starting to see a little bit more heaviness around their nasolabial folds and their marionettes, who their brows are maybe just not sitting quite as high as they used to. They're just losing that definition along their jawline. I think these are good candidates for treatment. I think people who have never touched their face and then come in their 60s and 70s, they have multiple factors that are contributing to what we're seeing. I don't think they're the best candidates. They may still decide to go ahead with it and accept the pros and cons of treatment, but I don't think they're the best candidates.
Yeah. I'll be there next week.
I was going to say we've used the words collagen stimulation, lifting, tightening. Now you go into social media and people get very uptight about these words, saying they're inappropriate and we're selling a dream and blah blah blah. So what do you mean by tightening and lifting? Because I know if I said that to a patient, they expect a facelift. Like it's just what they expect, right? So what do you mean by that?
Yes, I think it's a dangerous area to oversell anything and to suggest that it's going to replicate something surgical. I think you will be on the wrong track with that patient. And I think that's, you're going to regret that in 6 months, 9 months time when they come back for checkups. I think as long as their face is not kind of hanging off their skin is not hanging off their face and they're accepting that, to me, tightening is making it firmer, making it a little bit more shifted in the right direction so you don't see the same shadowing. I think it's not going to reposition, this area to here. It's not going to move skin from one location to another like a surgical facelift will.
Yeah.
But I think it will make their skin tighter in terms of making it more I think if you can stimulate collagen in those deeper layers of skin, I think we can make the dermis better. I think if we can target that scaffold system that runs through the skin, we can kind of condense in the face. We can narrow in those scaffold poles, the fibrous tissue that's running through from the fascia up to the underside of the dermis, and contract that in. And I think it firms in that way. It kind of pulls things together again. It doesn't remove anything. And I think, but nothing non-surgical will. I think we have to be clear with people that they're not going to get this kind of massive shift in the position of their face. It's not capable of doing that. What it is capable of doing is making them look better over a course of months or even years, making them more... I agree with you. I think lift is tricky, because lift is kind of one of these things that's just like, everybody wants to be lifted, but how can you measure how much lift somebody is going to get?
Yeah.
And, I've done vector, you can use 3D photography and you can kind of measure repositioning. You do see movement of tissue, but in more than a kind of contraction form, I think. It kind of it kind of pulls things together, like it kind of shrink wraps things a little bit.
Yeah, that makes sense. Are your patients the same as mine, where they say, I only want that, and they do the 2-finger facelift where they yank up their face 3 or 4 centimeters?
Yes, and that's
only what they want.
They don't want much. They just want this, nothing too much.
Yeah.
They still want it natural, obviously.
Okay, good to know that all of our patients are the same.
I think that my take on that would be, if they're really not up for surgery and surgery is not something they were willing to consider, I will still think about using Ultherapy, but I'll combine it with something else. I'm not going to get everything with Ultherapy for those people that are looking for this degree of lift.
Yeah, I was sort of joking, but it's worth labouring that point, because I think if you don't establish what that expectation is, then don't proceed, or proceed with caution, and take good photos and all the rest of it.
Yeah. So how would the treatment/results differ from, say, like a deep collagen stimulating injectable, say like a sculpture, which has been around for a long time, originally indicated for lipoatrophy, is experiencing a bit more of a renaissance period at the moment, people sort of seeing the benefit of it and utilising it in all sorts of places, including the bum, which is kind of interesting. But how does it differ in terms of the results? Is it sort of achieving a similar outcome in a different way, or is there some delineated differences between how these technologies differ from these injectables, collagen stimulating products?
I think primarily Ultherapy is not going to recreate any new volume. It's not going to give you such an abundance of new growth of tissue that you're going to be volumized. So Ultherapy for me is about non-volumizing, tightening, firming, to an extent, a degree of contraction of the tissue, so you get some illusion or appearance of lift. I think for me, collagen stimulators are really useful, and I would use them a lot, and I combine them a lot with Ultherapy. Right. Their place for me is more to improve the quality of the dermis. So we're improving through collagen stimulation and stimulation of the extracellular matrix, better quality skin, and arguably better quality connections that run through the fat, so these kind of fibrous connections. Ultherapy is going deeper as well. Ultherapy is really targeting that fascia layer, that this, in the bulk of the face, the SMAS. So it's really trying to target that fibrous membrane structure that's running through the layers of the skin, and therefore impacting the connections that run from the SMAS up to the dermis. Whereas I tend to think of biostimulators really working more in slightly more superficial layers, so subdermal, maybe subcutaneous. But really with Ultherapy, we're trying to get a little bit deeper, because we can see that with our visualization, so that we're really trying to work on the scaffolding that's running through the face. But I think these people do very well when you start combining it, because unless there's very few people who I think only needs one Ultherapy and they're done, they're going to be perfect after a few months. Most people will benefit from these combination treatments, so that you're really tackling multiple causes of their aging appearance. And so I think the role of collagen stimulators is great. I'm a big fan. I've been using them for a long time.
I don't know if it's off-label, and we can cut this out if you want, but I'm assuming you use a Merz biostimulator. So do you have a protocol where you combine that with Ultherapy? And if so, how do you sort of time your treatments between, Ultherapy and that?
So I will, as part of that original assessment, so if they're a little bit volume depleted, but I can see that they've got that kind of laxity, they've got some, you can assess that they've got a lack of collagen and elastin, but they need volumized, then I would typically use collagen stimulators first.
Mm-hmm.
And I would treat them maybe 1 or 2 sessions with that to try and fertilize the ground a little bit, try and re-stimulate the tissue to be in better working condition. We know that some of the biostimulators actually activate the fibroblasts and reinvigorate them. So that's a great thing. We can kind of time them and turn them on again so that they are ready to be more active at making more quality collagen and elastin. And once they're revolumized, then I would do the Ultherapy. If they come in and their volume is quite good, it's more of a sagging laxity issue, I might do the Ultherapy first, and then I might combine it with diluted collagen stimulator, just so that we really then improve the quality of the tissue and the appearance of the skin. So really trying to work on improving the appearance of the dermis. So if it's volume, I'll collagen stimulate first, and then I'll do Ultherapy. If their volume is pretty good, I'll do Ultherapy first to try and get them a bit more lifted, and then work at improving their skin quality with diluted collagen stimulators.
Okay. And I guess a similar question to David's, but, different modality. A lot of our listeners were asking, well, what's the difference between Ultherapy and, say, radiofrequency microneedling? Lots of devices around and a lot of hype around some of them. But again, I guess they're trying to, use your term, shrink wrap the face and plump the skin. So I know they're different technologies, but what in your experience is probably a better outcome?
I mean, I think fundamentally, I guess they're offering something similar in that it's fractionated. They're sparing tissue in between each of the areas where they're heating. Ultherapy does that by, micro-focusing ultrasound to create these little, they're called thermal coagulation points. These just tiny little injuries of heated tissue with spare tissue round about it. And I guess that's the same principle as RF microneedling, that it creates some degree of trauma, and then there's a heat source at the end of the needle to denature the tissue, then to trigger collagen production. From my perspective, I don't have RF microneedling, although I see a place for it as part of our lineup of treatments. The benefits of Ultherapy is that you're not breaking the skin. We don't have to penetrate the skin, so you don't have to deal with. From my experience, you don't have to deal with that aspect of it, of the kind of wound management and the appearance of the skin afterwards, and minimizing risk of infection and bruising and bleeding. And you don't have that with Ultherapy. We're bypassing the surface of the skin. The downside is that we are bypassing the surface of the skin, and so you're not getting treatment going from the epidermis down to your target layer. You're having to pick the layers with Ultherapy where you want to focus in on. But because we've got multiple transducers with Ultherapy, you can pick a different transducer to get to the layer that you want, but still bypass the surface. So for people who don't want to factor in too much recovery time or bruising or too much swelling or pinprick grid marks all over their face, then we have the option of using Ultherapy. Lots of clinics will use RF microneedling. Is popular just now. I think it's just an alternative technology, but it's not the same. It has pros and cons in terms of. But for me, the main benefit of Ultherapy is I don't have to deal with the breaking the barrier of the skin.
Okay, well, so with that in mind, what would a typical treatment protocol look like? So for people wanting to explain this to their patients potentially, so things like, we've sort of covered patient selection, but how many treatments are they going to need? Is it just one? Is it multiple? How long in between treatments? And then I guess on the day of the actual procedure itself, what's that like for the patient in terms of, how painful is it? Do you need to use any sort of pain relief medication, downtime, recovery, so on? So just take us on a bit of, that patient journey.
So it's relatively straightforward. They don't have to do much preparation. I mean, for most people, we would encourage them to be, I would start people on skincare first. I'm obsessed with skincare, but I like their skin as much as possible to be prepared prior to any treatment. But in terms of the Ultherapy section, they don't have to do anything at home. we typically get them to come in a little bit early because we factor in some pain relief, which we can talk about if you want me to go into detail about that. But I allow for that, like most kind of treatments that we're doing in our clinics that take a reasonable amount of time. We have to factor in some degree of pain relief just to make that more comfortable for our patients. The assessment process Jake mentioned earlier, I mean, we're rigid with photographs. It's really important that they have good baseline photography. It has served me very well over the years to be able to refer back to where their starting point was. Because Ultherapy kind of just gets a little bit better over a longer period of time, they don't notice that change day to day like they notice their toxins suddenly kicking in at a week. So we have to have good photography to be able to refer back to. And I'll sometimes also use 3D photography just so we can look at things from different angles. We can measure volumes. We can then, in subsequent sessions, measure degrees of shift of tissue or of volume repositioning. So baseline photography is important, and will always benefit you in the future when you're doing your reviews, or even just when you're looking back over a period of time. I think it's really valuable to be able to see how the process is going. The actual physical treatment, they lie down as basic stuff. They lie down. We tend to draw over their face. We mark out key landmarks that we want to avoid. We want to assess, as Jake was talking about, we want to assess, the quality of the tissue, so the degree of skin damage in terms of collagen, the elastin loss, but also kind of try and get an idea of the degree of laxity of the skin, which would be an assessment really of deeper tissue laxity. So I slide their face around and feel where I can get more movement and where things are more attached. That gives me some assessment of how adherent their fascia is through the tissue up to the dermis, because that's one of the target layers that we want to really go after with Ultherapy. We want to treat the fascia because that's really where it's these collagen-rich tissues. We want to treat the fascia and the deep dermis. So you make an assessment of those two structures, and from that start to work out where you want to focus most of your treatment and what areas are going to be only requiring some lighter treatment. And then I use the ultrasound. I mentioned at the beginning that the machine has the therapeutic and diagnostic ultrasound. So I use the diagnostic ultrasound. I look at their skin, I look at the thickness of their dermis, I see how thick their fat is, I see if I can get good contact between the transducer and the skin. I want to look at areas where the bone is more visible, where there might not be as much soft tissue coverage. And so by looking at all that, I can work out what transducers I need to use, how much pressure I need to apply in certain areas to be able to deliver that energy and be able to hit the structure that I'm trying to hit. Because there is no point firing that energy, wasting that energy, firing it into something that doesn't have the capacity to grow collagen. It's futile and potentially damaging. So it's a good assessment phase as part of your treatment. You use the Ultherapy device to plan your treatment. And once you've done that, that doesn't take that long. Once you get skilled at doing it, you kind of zip around and look at the key structures and map out what you're doing. And then you deliver the treatment. And I work in grids, and it's a handpiece you apply to the skin. You just move it in sequence up to the skin. So then we actually hold the transducer just onto the skin surface. And then when we are confident that our placement is as good as possible, then when the machine is activated, it fires a row of pulses of microfocus ultrasound. And so the ultrasound is concentrated at these dots, focus points. And that concentrated ultrasound is really what creates heat. You want the heat up to a certain temperature so that it denatures and that's what stimulates your collagen production from that point on. So we just work our way around the face, different sections, different panels. The machine is able to kind of record what we're doing, so we can keep a record of it that way, and it keeps a record of your number of pulses and the energy settings and the serial numbers and all these things, so that you have medical records built into the machine as well, which is really useful to refer back to. And then, so once we've completed the whole treatment, and typically I try and do full face treatment, so that would involve under the jawline, the lower face, around the eye, the brow. But we can treat multiple areas. We can treat necks, décolletage. Those would be the kind of standard areas to treat. There's, in my practice, we would treat on body as well, but that's not something that's typical, and that's off-label.
Okay.
But there's lots of applications for it. And then in terms of patients afterwards, they can walk out the door. There's nothing they need to do afterwards in terms of skincare or wound care or aftercare. They can, as long as they feel good, they can return to their normal day-to-day life, and it doesn't stop them doing things. And that maybe contrasts to some of the other tightening treatments where it might have some more degree of downtime. I'm not saying Ultherapy never has downtime, but for the vast majority of people, it's very, very manageable. It doesn't impact their day-to-day function.
Right.
You did mention that you have to prep them with some sort of analgesia. So what are you doing? I have heard anecdotally it's a little bit bitey, but maybe the technology's evolved since the older versions. I don't know.
Yeah. Are we talking Panadol or Pethidine? Like, how far are we going?
It's
Propofol.
It's, I think it's misleading to say it's not painful if it doesn't have some discomfort. I think we have to be realistic with patients. But lots of treatments have a degree of discomfort. Now, I don't do erbium laser resurfacing and don't prepare them and give them numbing cream and analgesia. Treatments have a degree of discomfort. We just have to plan for it. Patients need to know what to expect and how that's going to look like on the day. So we have a protocol in the clinic that we follow. Some people, if they're just doing very small areas, like they're just doing their upper face or their brow, they would need nothing. Those treatments are quick. They're kind of 15, 20 minutes. At a push, they might need some nitrous oxide. I tend to use nitrous oxide and oxygen for people. And that would be more than sufficient. If they are doing a full face, then that's going to involve the upper face and the lower face, and they're going down their neck, if we're including the neck. For most of those people, I will get them to come in a little early. We follow our protocol, which is, it ranges from paracetamol and ibuprofen. Sometimes I'll add codeine. Occasionally I'll add a short-acting oral benzodiazepine, just so, if necessary. But that, it varies person to person. But I make sure that they're adequately comfortable, because I don't want anybody being uncomfortable in the clinic. As a doctor, if I've got the ability to prescribe and do things for people, I don't want anybody leaving the clinic thinking, okay, that was not pleasant. Whether that's Ultherapy or having their lips filled or laser resurfacing, whatever it is, I want these experiences to be as positive as I can.
So you would never do sort of local in an area? It's all sort of, or is that sort of maybe complicate the treatment because of the liquid in that area?
So I don't do local anesthetic. I will sometimes apply topical local anesthetic, and I'll use like laser resurfacing anesthetic, which, leave it on for 45 minutes. And that helps when we're doing the very superficial patterns with Ultherapy, which is down at the 1.5 millimeter. It does help with that. When the 3 depths that Ultherapy works at, the 1.5, 3 millimeters, and 4.5 millimeters, I think the numbing cream doesn't adequately numb those deeper layers. Some people have in the past injected local anesthetic or done nerve blocks. I actually also want to know if they're really finding it sore. I mean, if they're really struggling, that to me is a warning that something was not right with with how the treatment's progressing. I mean, if they are jumping off the bed, I think that needs to be known. So I don't do nerve blocks or infiltrate local anesthetic. I think because we're applying heat, and because from that heat, there's a potential for thermal injuries. I kind of want to know if it's getting to a point where it's unmanageable. So I don't do nerve blocks.
Right.
I have to agree with that. I don't like doing nerve blocks for lips or anything really. Maybe hands for hyperhidrosis, but everything else, like you kind of want some feedback and also the patient to have a normal repose rather than sort of twisting their face because I can't feel their face. So, yeah.
It's true. I mean, it's really important that we look after the pain aspect of any treatment. It's people from a business perspective, they have to leave the clinic and think, okay, that was a positive experience. It wasn't horrendous, that I'm never going back and never doing that again. Because these, a badly managed pain during any treatment is a deterrent to them coming back. And I think aside from the therapeutic endpoint, from a business perspective, I don't want people leaving thinking that was awful. I'm not doing that again. That doesn't help my clinic.
Yeah, not a good way to get referrals.
Not really.
No, not really.
Yeah, go on.
I was going to say, you've mentioned the ultrasound component, and of course there's aesthetic ultrasound for diagnosis and treatment, and then there's Ultherapy for microfocused ultrasound under vision. So are they the same skill set, or is Ultherapy pretty easy to pick up? Because I know a lot of injectors have sort of thought about bringing an ultrasound for safety, and yet when they've had a look or even done some online modules, they've been put off by what they're seeing on screen and getting a bit complicated. It looks a bit complicated sometimes. So what's the learning curve, I guess, is my question.
It's so the actual fundamental learning. So when you get Ultherapy, or when I got Ultherapy and you start using it, I mean, this was years ago. I've had it for a long time. It's it does take a bit of time to get your head around what you're looking at. But I think Ultherapy, because I have, like you, I do a little bit of ultrasound. I'm not amazing at it, but I do a little bit of ultrasound in my clinic just because I've been used to ultrasound therapy for a long time. But there is quite a steep learning curve with it, just orientating yourself to what you're looking at. And, when you change the position of the transducer, how things are looking differently. And it kind of all looks a bit the same. I mean, the Ultherapy ultrasound is good because it's not, the resolution is not as high as some of these portable ones. And that's a good thing because you're just looking at basic structures. You're looking at dermis, you can see fat, you can see fascia, you can see bone. And so I think from a learning experience, it's actually, I think, a little bit easier because you can it's pattern recognition. You can see these images and you just start to work out what you're looking at, I think, easier than when you're doing lots of movement and changing angles and doing Dopplers and doing all these fancy things with handheld diagnostic ultrasound. So the learning process is, it's a new skill, but I think it's easily acquired. I think you start to kind of really work out what you're looking at. And you just, from Ultherapy's perspective, you need to just know what those key structures are that you're targeting with your energy.
Yeah.
The actual delivery of the energy is relatively straightforward. Once you've matched up where you want to deliver that energy, and you're confident that your contact between your transducer and your tissue is as good as possible, so that every time you fire the transducer, that you're going to get effective results. And I think in the past, that's probably where things have gone wrong, not just with Ultherapy, but with other HIFU devices. They're kind of just firing it everywhere and hoping that it's hitting the right spots. And I think for me, that's the big difference. When I can see what I'm doing, I know then that I'm delivering it to the right place, and therefore I'm going to translate that into clinical therapeutic results. If you're firing energy all over the place, never quite sure where it's going, it's pot luck whether you're hitting the right structure that's going to grow collagen.
Yeah, it's a really good point. Just to sort of make it, I guess, more explicit, you said there's 3 heads, 1.5 millimeters, 3, and I think 4.5. So you just change these heads on the ultrasound so they fire at different depths. And is it as intuitive as, say, you're doing, I don't know, the brow where it's quite thin, you choose the 1.5 versus, let's say a thicker piece of tissue where you're trying to treat the SMAS, you're highly likely to go for the 4.5, and then you look to see if the tissue's there to sort of target.
Yes, I mean, I think there are obviously protocols and guidelines which give suggested treatment patterns for different areas of the face. But interestingly, there was I don't know whether you read it, there was a study a few years ago related to Ultherapy, but it was Gabriele Casabona and Sebastian Cotefana looking at the variations between SMAS depth, dermal thickness, across different age groups, different sex, and really, really highlighting the fact that our faces are quite different. That your face is different to mine, is different to my 80-year-old neighbor. Our faces are, and we cannot treat everybody's face the same. And I think as a differentiator between HIFU and Ultherapy, the Ultherapy has that ability to make those personalized, customized adjustments to the face that you're treating, not assuming that everybody's SMAS is 4.5 and their dermis is 3 millimeters, because we know it's not. So there's good study evidence that show that we're not the same. And so if you treat everyone the same, as I said earlier, you will end up hitting the wrong structure. And at best, you will get no results, and at worst, you'll get a complication because you've hit the wrong structure that you're not intending to target. So, yeah, I mean, to tackle back to your question, there are kind of broad guidelines about what we would recommend in different areas of the face. But we really would encourage people to use the visualization to personalize it to the face that they're treating, not just assume we're all the same, because we know that that's not the case.
Yeah, that's a good point.
Yeah. So you used the word complications. So what kind of complications are we talking about? Like what's possible? What's maybe like a less commonly seen complication versus something that, potentially could happen? So you sort of alluded to the fact that if you hit, the wrong structure, what could we potentially be looking at?
So my experience would be most side effects are minimal. They will get some, I think acceptable to most patients, they'll get some flushing, they'll be red afterwards. Sometimes when we use the more superficial transducer, the 1.5, they will get some degree of superficial swelling. So sometimes they'll see kind of wheels, and they will disappear usually relatively quickly. By the time we finish the treatment, sometimes it disappears. Certainly by the next day, they've generally gone, and that's just from some superficial swelling in the dermis. More, they can be a little bit tender. When I've had Ultherapy before, your face does feel a little tender afterwards. It's had hundreds of tiny little dots of 65, 70 degrees heat fired under it. It's a little tender, but not enough to stop you doing something the next day. Some people will swell. Again, most people can be planned for that and won't be too upset by that. We can kind of anticipate based on previous treatments that they've had who might be a sweller. Bruising is rare. Pain afterwards is not really a big problem. There are a couple of nerves I mentioned earlier when we're plotting out our treatment and we're kind of mapping out where we're going to treat. We try and avoid areas where we know, like the marginal mandibular nerve, we'd be sitting. We'd be careful around the kind of supratrochlear nerve. Even if you do inadvertently hit those nerves, it's unlikely you're going to cause anything at all. You might just feel a little bit of a ping from the nerve, and then to avoid that area and you just remap it and remark it. If you keep hitting that nerve maybe over and over again, certainly there have been a few cases of short-term neuropraxia, just where they feel the nerves a bit uncomfortable, or it's usually sensory symptoms, and they have always resolved after a few weeks. So there's never been any cases with Ultherapy reported that we know of any nerve damage to the skin. Again, you have to be careful with, I mentioned, it's hot, it's 65, 70 degrees. So that contact between the transducer and the skin has to be good. You can't have them jumping and pulling away from you and losing contact between your transducer and the skin. So that's the reason I sometimes use a light benzodiazepine. If they're fidgety and nervy, sometimes we'll use just something a little bit light just to help them relax, so that I can keep better contact between their skin and the transducer, and therefore make it a safer treatment. It's not about sedating them; it's making it safer for them.
Yeah.
HA fillers. Is there any sort? You sort of mentioned 65, 70 degrees. Is there any sort of issues with that sort of heat affecting the HA integrity, or, Jake shaking his head saying no?
No, I'm going to let the expert answer here.
As a layperson, it's an obvious question to me.
Yeah. I mean, it's always been one of these things that people have asked, can you melt HA filler? I don't think so. I don't think, sometimes you can see filler on the ultrasound, the diagnostic ultrasound, particularly if you're treating around the eye and they have a collection of filler, you can see it on the ultrasound. So the majority of the time I can avoid it. So unless you're deliberately trying to disrupt the filler in some way, but I don't think it melts the filler. I wouldn't, if I had the choice of sequence of treatment, do Ultherapy first and then their filler afterwards, rather than do their filler first and then a week later do their Ultherapy. And partly because the tissue planes have been adjusted a little bit by the injection of filler. Partly they may still be a little bit swollen, so you're maybe not getting a good reflection of what they look like. So I think if you had the opportunity to do Ultherapy first and then filler subsequent, but I've certainly not been convinced that it can melt filler at that temperature.
Yeah.
And it's microseconds. I mean, the amounts of time that the energy is creating that heat is super, super short. So I think you really have to expose filler to higher temperatures for longer and really bulk heat filler at high temperatures to have any impact on the structural integrity of HA.
Yeah, it's a similar question for laser. If you're lasering at say 70 degrees, is that going to melt the filler? And I spoke to Professor Goodman and 100 other people, and they're not convinced and that there's any effect. I mean, I think you're right. Just because you can't melt a filler doesn't mean you can't sort of change the architecture around the filler and maybe create some puffiness or change. But actually removing filler, I don't think is a real thing. Okay. But that does lead on to, I guess, a controversy of all of these technologies, which is melting fat.
Yes.
Now, sometimes you might want to do that deliberately, say in the submental area or, I don't know, somewhere else. But, one of the things that was floating around for many, many years and I guess sort of argued about hotly on Instagram particularly was, some patients would say, well, I had not necessarily Ultherapy, but one of these technologies, and they felt they looked saggier and hollower after the treatment or after the protocol. So what's your take on that, Stephen?
So similar to filler, I don't think, so my view would be, I don't think fat can be destroyed by the amount of energy that we place into the skin with Ultherapy for the duration of time that we expose tissue to the heat energy. The other thing I think is important is we actually don't want to treat fat. Well, certainly I don't. That's not the objective of Ultherapy. And we're using that visualization to avoid fat. I'm trying to target deep dermis and fascia because they're the structures that have the most abundant potential to be able to grow new collagen. And so actually it's really not desirable for me to waste that energy going into fat tissue because it's not going to trigger the response that I'm looking for. So I guess that's the first thing, is that it's not an intended tissue. If you inadvertently fire ultrasound into fat, I don't think there's been any convincing publications that it would cause significant damage to and the volume that you would have to treat and the amount of energy you'd have to put in and the time you'd have to expose that fat tissue to heat would be far, 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 far greater than what we're ever achieving with ultrasound. But the other thing that I think is important to differentiate is that, and it goes back to actually what I said a second ago, we know where we're treating with Ultherapy because I can see it and I can avoid things I want to avoid and treat things that I want to treat. And I also know with Ultherapy, just because of the way it's been engineered, and there's a really great paper was published maybe earlier this year or last year, looking at the kind of engineering of HIFU and Ultherapy. They looked at 4 devices. There was 3 HIFU devices and MFUV, which is Ultherapy. And they looked at the kind of characteristics of the different machines and from an engineering perspective, how much energy they were putting out, how reliable they were at modifying the temperature regulation, what the spacing was between each of these thermal coagulation points, these heat spots. And they looked at the shape of these thermal coagulation points as well. And interestingly, with Ultherapy, they're they're not quite, they're almost perfectly spherical. And they are almost perfectly distributed. So when you do biopsy samples, like you can see these thermal coagulation points beautifully lined up. I mean, it's like architecture. I mean, it's beautifully constructed. And there's spacing in between, almost identical spacing in between each of the points, which then allows this kind of fractionated technology to then allow kind of surrounding tissue to be able to facilitate the repair of adjacent tissue. And that's not the same with all HIFUs. HIFUs vary considerably in what they deliver. Some of those thermal coagulation points, unlike Ultherapy, where they're kind of almost perfectly spherical, are more like starbursts. So they're kind of much more superficial than what they're reported to be delivering at. There might be an elongated distribution of the thermal energy, meaning that it's treating deeper than you think, but also more superficial than you think. So I think there's a big variation in how the machines deliver energy, and that might contribute to damaging fat. Because if you think you're delivering it into the fascia, but actually your HIFU device is delivering it into the more superficial tissue, maybe you are targeting fat, not knowing that you are. And for me, I don't see why you wouldn't want to be able to see what you're doing. We don't close our eyes when we're injecting and hope for the best that we're going to achieve the right result. But why would you want to this is my opinion, but why would you not want to see what you're doing with when you're delivering this energy? So I can see it, and I can avoid things, and I can treat things, and for me that makes it safer. And that paper's great. It really shows the variation between the different technologies, and I think that's important. We have to go back to science, and we have to go back to we get caught up and we're very seduced by marketing and by trends and what people think are popular and buzzwords and keywords. But, I think if you're deviating too much from science as a doctor, I think you should be thinking how you're practicing.
Yeah, it's a good point. In fact, you supplied us with a number of papers, and thank you to Merz for that when we were researching this episode. So we'll make those available for all of our Patreon subscribers. So, you guys can dip in and read all the science. And Stephen, I think you wrote one of the papers with Niamh Corduff, one of our previous guests as well. Tell us about that one briefly, because I think it's your protocol for how you go about, actually using the device.
Yeah, so Niamh asked me if I would help just... we split the centres between her clinic and mine. We were looking at if we could modify the protocol from the standard pre-established protocol and reduce it into smaller, maybe more manageable treatment sessions. Because we know that the things, as you've mentioned, the things that concern people potentially about Ultherapy is this concern about pain, even though I think we can manage that and address that well. But we were thinking, okay, well, what happens if we divide the treatments up rather than do one bigger treatment that might just be getting a little bit too uncomfortable by the end? What happens if we do that over 2, 3, 4 treatments and just make them short and sharp and then pick up where we left off the next time we see them? Can we achieve the same results? And we could. There's the outcome from the study, which was published just a couple of months ago, was that it was non-inferior to the traditional standard, do it in one go and you're done. But our pain scores were less, and we were able to get the energies a little bit higher. And it was very acceptable to patients to do them over a few sessions because they could spread the cost. They could divide it up over a couple of sessions or 2 or 3 sessions, which may be more appealing to them. But also they could fit it in with their work schedule or their lifestyle a little easier as well. So we looked at a few things. We looked at patient satisfaction. We looked at pain scores. We looked at Vectra 3D imagery. We looked at Visia to see if there are any skin quality changes with Ultherapy, which there were. We actually got quite a lot of data about some skin quality improvements as well as this kind of volumetric lift. But interestingly, and quite good to support the original data, is that our results were consistent with the very early publications that got the original FDA approval. We got the same degree of brow lifting as the original studies and the same degree of submental improvement. So we were able to reinforce the basic science that supported its FDA and TGA launches.
Fantastic.
It was good. We contributed to the that fundamental evidence that supports its use.
Yeah, that's great. Now, on to a couple of, I guess, business and logistical questions, which is always David's fun bit at the end. I'm curious to know, how big is the device? Like, if you're thinking of buying a device and you've got, maybe reduced space in your clinic, where does it live? How cumbersome is it? And, how often are you having to service it? All that kind of stuff.
Mm-hmm. It's not that big. The actual unit itself is like an old-fashioned big laptop. It's about 60 centimeters. Maybe it has a flip-up screen. It's got a touch screen that you can record your notes on, and it has the ultrasound built into that screen as well. It comes with a transducer handpiece, and you slot, as you mentioned, these different transducers into it. It comes on a trolley that's on wheels. So it's about 60 odd centimeters, maybe by 60. It's that kind of size. It's not any bigger than a very small laser. It's portable. I can wheel it between different rooms in the clinic. I tend not to leave it in one room, but you can move it around. It comes out in a big carry case. You can take it if it's somebody who is working in different clinics. They're not based in one. They could pack it up and take it with them. It comes in a travel case. It's never, mine's never been serviced. I've had it since 2016 or 15. I've had a couple of times where I've needed to get the handpiece serviced. So it's been very reliable. That's my experience with my one. Anyway, I've not had any major problems with it at all. I'm not just saying that. I've generally not it's probably been one of the most consistent machines I've had in the clinic. Lasers, I've got lots of lasers, but lasers need to be serviced. The flash lamps go, something goes with it occasionally. I've actually had very, very few treatments where I've had to abandon the treatment with Ultherapy. I think it's maybe happened once, and that's because I to do with the handpiece. But it's been pretty reliable. It's been one of my better purchases over the years. It's your other question. I'm sorry, I've forgotten your third question.
Maybe we'll talk about some money, and I promise not to make any Scottish jokes about money. All right, so
it's the cheaper the better.
Yeah.
Scottish
My cousin said he's got short arms and deep pockets, so I don't know.
Yeah, exactly.
So, I mean, where does this sort of stack up in terms of, if you were to spend an hour treating a patient for fillers and toxin versus doing, and I know we're not doing treatments for patients based on how much you're going to make, but I mean, to give people a comparison of the value of their time, what does it kind of look like in terms of what do you charge the patient? I know we're probably going to get into a little bit around how you can, target different zones of the face. You don't have to treat the whole face, so it can sort of become a lot more affordable. But in terms of return on your time, how does it compare to other treatments, and what's it costing patients?
Yeah, so I mean, our treatment times are generally between, if we're doing a face or a full face, like an hour and a half, they might be in the clinic. So it's a reasonable amount of time they're in the clinic. It can be done, you can delegate it. So I mean, if you choose to train up, I have a nurse and a dermal therapist that I've trained over the years to also do the treatment. I don't do them all myself. I still do a good chunk of them myself, but I have trained some of the other staff in the clinic well so that they're very competent to also deliver them. And from a business perspective, that would be helpful because there's, you perhaps have less overheads with some of your additional staff. They're consumable for Ultherapy, aside from your repayment of the machine. If you purchase the machine, is the transducer. You have to buy new transducers. So the transducers have a number of available pulses or lines on them. And then once they have been used up, then you have to replace the transducer. So that's your ongoing cost. There's no other cost in terms of running the machine, but you need to have a supply of transducers because once it's empty, it's empty. You can't deliver energy at that line. So that's your ongoing cost that you have to factor into your profitability from your treatment. But you can charge a reasonable amount of money for these treatments. I think they're offering something different to your tox and your filler. You're really trying to provide something that's going to be a longer lasting treatment. It's really trying to work at that kind of whole scaffolding of the face. I think it has a different selling angle to your toxin filler. But the way I do it is that, I have treatments that in my clinic that are more profitable and I have treatments that are less profitable. But when I mix them all in together, then it all works out in the end for me. And I know that then I've really targeted all of those layers of the aging face, and then I get better results. I get more patients. And I'm aware of what the profitability is for all of our treatments in the clinic, but it doesn't come into my decision making when I'm thinking, what's the best thing here? Because I know another treatment that we offer is going to kind of balance everything up. But they are, for me, even if I do them versus the nurse or the therapist does them, they remain decent, profitable treatments.
I got a question because I'm one of those injectors who injects. I don't have any devices. I mean, of course, I work in a clinic where I can, internally refer for laser and even surgery. But I guess I've always been a little bit reticent to learn devices because, I mean, like you said, you can delegate to other staff. And, my sort of business brain says, well, just stay in the lane and just do injecting because that's what you're good at. But I guess my question is, what drew you to wanting to master a device when you can delegate it? Like, do you get enjoyment from it, or is it just seeing the results that's the most satisfying thing? What is it that, made you passionate about it?
I mean, I do enjoy doing it. I mean, lots of people have said in the past, oh, it's so boring. You're just kind of doing one line after the other. It's so repetitive. But and maybe that is the case for some of the other devices. The ultrasound aspect of it, I think, makes it interesting because it's real. It's like real time. It's when I'm moving the ultrasound, I'm seeing it happening at the same time, and it becomes a kind of an addictive challenge to yourself. to make every shot the best you can. Like you're on a mission to kind of optimize everything you're doing, and you become really internally competitive at getting better results than somebody else. I don't know if this is me, and this is probably it's not a desirable thing, but you want to make every shot you do count. And so I challenge myself to make it as good as I can every single time. So I actually don't find it monotonous, because it keeps me interested. Like I'm watching all the time and I'm maneuvering it, and I'm kind of challenging myself to get this best result. It keeps me occupied. I trained other people in the clinic because I do enough of them that it takes up too much time for me just to do it. It's, if it's 90 minutes, that's a good chunk of time where I could see a number of toxins or fillers during that time. So it was more just a logistics of being able to spread the load amongst the clinic staff.
So what are patients sort of roughly looking at per treatment? So maybe let's look at per zone and then for a full face.
Yep. So if we're treating upper face, or if you're treating the kind of brow area around the eye, that might be, I think it should vary depending on the experience of the person doing it, but around about $1,000, maybe for $1,000 for the upper face. And that's to treat around the eye. For doing the kind of lower face, I try and do the whole face if I can. So I do from under the jawline and up and around their eye, because I think you get a better result if you kind of globally treat the face. That would vary somewhere between around $3,500. And then if you're treating kind of necks, if you're going down to the décolletage, if you're treating everywhere in one go, you could be the best parts of 4,500, 4,800, 5,000, something like that.
Okay.
It's reasonable investments. I think, and it goes back to one of the very early points, that you have to pick the right people, because if they're spending this amount of money, you need to give them a result. It's not acceptable to pick the wrong people, take their money, and then them be disappointed in 6 months. It's the worst feeling when you see somebody and they've invested this time and effort in 6 months of time and you've not delivered something for them. So I think you get better at doing that with more experience. I think that applies to toxins and to fillers as well. You just get better at saying no to the wrong people and yes to the right people that you can help and give them great results.
Okay. And what are the cost of your transducers?
So the transducer carries 2,400 shots or pulses. So I have one for each of the 3 depths, the 1.5, the 3, the 4.5. I also have a narrower transducer for the 1.5 and the 3, which has got a narrower window, which lets me kind of get into smaller areas or around the mouth. They are around that. That's probably something to contact Merz about, but they're around about $2,500 ish.
Okay.
To replace the transducer.
Yeah.
And you'll get 2,400 shots out of that. My average treatments for the full face are around 800-ish shots would be a kind of average kind of treatment. So you can kind of work out the maths of that you're using about the equivalent. You're switching between different transducers, but you're using roughly the equivalent of about a third of a transducer, which the whole transducer is costing you 2.5, but you're charging maybe 3 for that treatment. So a third of the transducer is profitable for clinics.
Okay, so that seems pretty reasonable to me.
Between depending obviously what you're charging and your overheads, but it's and whether you're repaying the machine or whether you've repaid it already.
Okay. I know that Merz have opened a new training center called the Friedrich Merz Training Center. Is that correct?
Yeah, Friedrich Merz. He was the founder of the Merz pharmaceutical company back in, I can't remember, many years ago.
Right.
120 odd years ago, I think he founded it in Frankfurt in Germany. So he was the founding pharmacist, chemist that set up Merz pharmaceutical company many years ago. And it's still his family. It's a family-owned company. They're still owned by the Merz family. Right.
So where's their new training center and what's there? I think they opened recently, and I gather you were there. So what happens there?
Yeah, so they've built a great space in Mascot, so really close to the airport. So great for people coming in for trainings if they're flying into state for trainings. They have their head offices there. They've also built a training center, which is great. They've got individual bays for supervised training if there's trainings happening in the clinic in that environment for both their toxin, for Xeomin, for Belotero, for BDS, for Ultherapy, and they're now offering trainings across all of their portfolio. There's also a kind of didactic presentation space that they're joining. It's great. They've got lockers and changing rooms. Like, they've made it really practical for people to be able to attend and get as much out of the trainings as possible. And they have a fridge stocked with drinks, which is very nice.
There you go. You just sold everyone.
You're well looked after. Yeah. It's a great space, and it's brand new, and it's all very kind of high tech kind of IT stuff. So it's great. Yeah. So they've installed clinical imaging photography as well, so they can really utilize the training space to photograph people and really kind of dive deep into the photographs and actually understand the anatomy. And it's good. They've done it very nicely, and it's going to be a great training space for us too.
Fantastic. Well, the reason I mentioned it is because, of course, if you're an existing customer of Merz, you can just call your rep and I'm sure they'll arrange training. But if you're not currently a Merz customer, but you're interested in maybe learning more about Ultherapy or even training, if you just go to merzaustralia.com.au, you can find all of the links and they will hook you up. But yeah, it's great to know that you've got a facility. I live in Mascot. I'll have to swing by and have a look. It sounds amazing.
You're very welcome to.
Fantastic. Yeah. Well, I think that's everything we had to ask. We asked a few curveballs. We asked about the downtime, pain. I think it was good to be honest about, all patients are different. They perceive things differently, and some sit there as if nothing had happened, and some sight of a needle and they're needing a benzo. So
no, it was great. I still don't believe you're 44, but anyway, that's for another discussion.
Well, thank you so much for your time, Stephen. Are you going to be going to Monaco, IMCAS, any of the sort of global events next year?
Yeah, I'm off to Barcelona next week. Merz have their kind of global event in Europe the end of the year, so it's next week. So I'm off to that. I haven't really committed to much next year. I'm certainly doing some kind of presenting locally and regionally in kind of Asia for Merz. I do some KOL work for them for that. I haven't really looked at any of the big conferences. What are you planning to? Have you got plans for any already?
I'm definitely going to Monaco, so that should be fun. And I'm trying to tack on some teaching in London and maybe in Norway as sort of part of that trip, just to make it a bit more efficient with the flights. But I was going to say it would be great to see you and share absolutely. A beer and catch up and have a chat about how your Ultherapy journey is going. But really appreciate your time. It's fascinating. I've not actually seen the device being used. So I don't know if you've got any videos. Maybe we could also get a video from either yourself or Merz and again show our Patreons exactly, all the things that you've described, but actually sort of in a video and maybe see how it works.
Yeah, I'm happy to be a guinea pig. There you go.
All right. Yeah, David's angling for free treatments again. Sorry about that. Well, you know where the training centre is now.
There you go.
Be one of the models.
Yeah, exactly. Why not?
All right.
Well, thank you very much.
Thank you for having me.
Yeah,
I
thank you.
It's lovely to spend time with you, so thank you for your time.
Thank you, and thanks for Merz for partnering with us. It's a great opportunity, and thanks for your support. And hopefully we'll get you guys back on again.
Brilliant. All right, well, Stephen, we won't take up any more of your time, but thank you again, and we'll speak soon.
Thank you.
Take care. For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloan and David_Inside Aesthetics.
Join our IA Patreon platform for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.